Good evening all. I welcome you all for the next session on Cardiology series by Dr. Rashmi Shivram ma'am. So today we will be just revising and recalling with a TND session. This will be the first TND session in our series. And today till now, what are the topics we have covered so far? We will be discussing about that. Thank you. Ma'am, please continue ma'am. Thank you.
A very good evening to all of you. So I'm very happy that you have joined back for this session again. So far we have covered quite a few important topics, like I told you in my introduction video that you've seen earlier. So it's now time that we actually, try to assimilate whatever we have studied. Solving questions is always a very good thing, is it not? So it actually builds your confidence. It helps you know where you actually stand, whether you have understood the topic properly or not. And you will also be able to, generate more new questions so that you will be able to understand the topic better. And you will get a clarity in your mind, whether you know the topic really or not. So even minute details, you might actually be able to refine it further when you're actually solving questions. Okay, so what I have done for this session is actually, I have not put very tough questions or anything. Questions are mainly based to boost your confidence. It is mainly designed so that it will boost your confidence. It will tell you that you have understood the topic actually. So what happens is, questions and answers, usually what happens is, the questions can be in various forms, is it not? But the concept is always the same. It's the same concept which will be asked in different ways, and a slight extension on and on and on. So that extensions are sometimes important because those fine details tend to be asked in NEET PG exams, is it not? And it's always good to know more, is it not? So what we have to do is, we'll be going through some questions. First we'll do some ECGs, and then in between we'll have some other type of questions as well. So you will get a wholesome idea. It will cover almost all the topics that we have discussed so far, and little more in detail also. Okay, so these questions are mainly to boost your confidence. So I would like if all of you can actually answer some questions along with me. You can post in your answers in the chat box. That will be good, so that you can do it at the same time, and you will also develop some confidence. Okay, so I'm sure this will be very easy questions for you. So try answering these and we will learn together. Okay, shall we start now? Okay, so this is the first case scenario. We have a 74-year-old man who has come to you for a routine checkup. He has a medical history of only hypertension. Other than that, he doesn't have any other history. Okay, so for this patient, you take an ECG and you have this ECG. So what are the findings in this ECG? Does this patient have left ventricular hypertension? Okay, the patient is worried whether his hypertension is actually affecting his heart. He comes to you with that. Okay, but he's come for a routine checkup and this ECG is obtained. So what will you do? How will you interpret this ECG? And is there any sign of LVH? Do you find signs of LVH? Okay, so shall we interpret the ECG right now? Okay, so first we usually start with the rate, rhythm, axis, and then we move on to the waves and the segments. Is it not? That's how we do the ECG. So first let us start with the rate. So this seems to be a fairly regular rhythm, is it not? This is a regular rhythm. Rate, regular rhythm, the RR intervals are equal. Yes. Okay. The rate is also, it's around 3 small boxes. Okay. Rate is around 70 beats per minute, I would say. Okay. Then what about the axis? So the lead 1 is positive. QRS in lead 1 is positive. And the QRS in lead AVF is also positive. So that means it is a normal axis. Okay. Normal axis. Okay. So what is the next one? It will be the P wave. You have to find out whether there is a P wave or not. So here you can see a P wave. There is definitely a P wave here. Sorry, here. Okay. So every P is followed by a QRS. P plus QRS is present. So this is a sinus rhythm. So this is a sinus rhythm. Okay. Sinus rhythm is there. Then what about the QRS complexes? They are all narrow QRS complexes, is it not? There is no wide QRS complex. So it is a narrow QRS complex or a normal QRS complex, which is normal QRS complex. Okay. So what about the T wave? So when you see this ECG, you can see that there are some T wave inversions. Here V4, in V5 you can see here, and V6, as well as in AVL. Okay. So there are some T wave inversions in few leads. T wave inversion is present. Okay. So coming on to whether this patient is having left ventricular hypertrophy or not, how would you say that? So as soon as you see the an ECG, what will you do? You will first look at the name and see whether it is correlating with the patient that has come to you. That is the first thing. You have to verify the demography. Okay. What is the second thing that we will do? Like we saw in our first class on the conduction system of the heart and the basics of the ECG, the second thing that you should be seeing is the standardization of the ECG. What is it? It is the standardization of the ECG. Standardization of the ECG. What do you mean by standardization? The ECG will be moving at a speed, is it not? 25 millimeters. That is the speed that it will be moving. So when that speed is normal, you will find that there is such a kind of a bar. But when you see in this ECG, you will see here that there is a different kind of bar. What does this mean? This means that it is half standard. It is half standard. Why is it so? It is because this patient is having a left ventricular hypertrophy probably, and the complexes, QRS complexes are very long and they don't fit into that ECG paper. So to give you a better idea, what we do is the voltage is reduced, it is half standardized so that you will be able to locate the waves properly. So that is called standardization. Standardization is very, very important. So if you don't notice this and you just see this ECG and you say the patient is fine, he's not having left ventricular hypertrophy, your hypertension is under control, just you can go home. So then the patient will be very lethargic, he won't be taking the medicines properly. But when you find out that there is a left ventricular hypertrophy and you treat the patient properly, there is a chance that the left ventricular hypertrophy can be reversed as well. Okay, left ventricular hypertrophy can be reversed. This is a very important thing to remember. So, in a patient who has hypertension, if he develops left ventricular hypertrophy, you can actually reverse the hypertrophy by giving correct medications, by giving appropriate medications and maintaining the BP under control. Okay, it is a reversible finding. So, this patient is actually having a left ventricular hypertrophy because this is a half standard ECG. The limb leads are normally fine, normally okay, but the limb leads are actually, but the chest leads are actually half standard. Okay, so what happens? How will you say that this patient is having a LVH? What is the criteria that you will follow? It is called the Sokolov-Lyon criteria. What is it called? Sokolov-Lyon criteria. Okay, Sokolov-Lyon criteria. There are some other criteria as well, which is called like the Cornell's criteria or the Lyon's criteria or the Framingham's criteria. There are some more criteria. Basically, these are all voltage-based criteria. What do you mean by voltage-based criteria? Voltage-based criteria means they are basically based on the voltage-based criteria. They are basically based on the height of the QRS complex. In the vertical plane, it is actually the voltage. In the horizontal plane, it will be the time. So when it is vertically elevated, when the QRS complex is long, that means the voltage is higher. Okay, so basically all these criteria are voltage-based criteria. Okay, so what is Sokolov-Lyon criteria? So what you can see is in V1, in this ECG, you can see that in V1, the depth of the S wave is more. Depth of the S wave, depth is more. Whereas in V5, V6, if you see, the R wave height is more. Is it not? R wave height is more, whereas in V1 and V2, the S wave will be, the depth of the S wave will be more. So this criteria is basically based on the S wave in V1 or V2 and the R wave in V5 and V6. Okay, so to say that the patient is having a left ventricular hypertrophy, the depth in S1, okay, the depth in S1 plus the height of R wave, the depth of S in V1 and the height of R in V5 or V6 should be more than or equal to 35 millimeter. Okay, this is the most commonly used. So the depth of S wave in V1 plus the height of the R wave in V5 or V6 should be more than or equal to 35 millimeter. Then you would say that this patient is having a left ventricular hypertrophy. Okay, so let us look at this patient. How about the depth of the S wave? Here you can see it is 5, 10, it is about 13 small boxes. What about this? 5, 10, it's about 12 small boxes. Okay, so this will be 13 plus 10, this is about 25. Okay, but this is half standard. So you need to multiply it by 2, which will be 50 millimeters. It is 50 millimeters, which is clearly more than 35, which is clearly more than 35 millimeters. So definitely this patient is having a left ventricular hypertrophy. Left ventricular hypertrophy is there in this patient. So what you should do for this patient, he's an old man, you have to give him appropriate medications, appropriate antihypertensives for this patient, and you can actually reverse this LVH to a great extent. And you can actually prevent the further cardiac remodeling which will happen and the other structural problems that can occur because of left ventricular hypertrophy. So this is very important that you note the standardization. That is why I always say basics are very, very important. You cannot overlook the basics at any cost. Okay, basics sometimes might cost you a really big thing. So this standardization is very, very important. And the other thing that you must remember is you should always verify the demographic details on the ECG. Okay. So let us move on to the second case scenario. So here we have a 68-year-old gentleman. He has come to you with a recent onset of productive cough. He's having cough with slight fever and shortness of breath occasionally. He's had a previous history of myocardial infarction, but he says, presently I don't have any chest pain, I don't have any substernal pressure, I don't have any excessive sweating or anything like that. Okay, on examination, his chest is showing bilateral bronchi and his X-ray is negative. So now you go on to do an ECG. Okay. So in this patient, the doctor near you, he says that this patient might be having a posterior wall MI. Okay. The doctor says this patient might be having a posterior wall MI. Would you support the diagnosis or would you go against it? Will you say that this patient does not have a posterior wall MI, or will you say that this patient has a posterior wall MI? How will you find out? And what is the axis in this ECG? That is what we are going to see. Okay, we are going to see two things. What is the axis and what is the whether this patient is having a posterior wall MI or not. Okay, so I think axis, you must all be thorough by now, is it not? We have solved quite a few topics in this. We have solved quite a few ECGs on this, and I think this concept has been explained very clearly to you. So I think you should be trying now to solve this ECG for the axis. Okay, so let us try. So what happens? Lead 1, it is positive. Lead AVF, it is negative. So we'll now draw the hexagonal reference system. Okay, hexagonal reference system. This will be 0 degrees, which is lead 1. This will be 90 degrees, which is lead AVF. Okay, so we saw in lead lead 1 it is positive and lead AVF it is negative. So we'll draw it in the opposite direction. So what happens when it comes like this? We have to look at lead 2. Okay, we have to look at lead 2. It is negative in lead 2. It is negative in lead 2. So it will be here. Okay, so the resultant vector will be somewhere here. This shows left axis deviation. So up till here, if it is there, then it will be normal axis. Normal axis. But in this patient, you have a left axis deviation. But in this patient, you will have a left axis deviation because it is the lead QRS is positive in lead 1, but negative in lead 2 and AVF. So this patient is having a left axis deviation. Okay. So now we are clear with the axis. What about the heart rate and the regular rhythm? It is regular. Heart rate is also normal. There is no tachycardia. There is no bradycardia. It is around 65 beats per minute. Okay. So heart rate is fine. So what about the others? So there is a P wave, definitely. There is a P wave. It is positive. So it is sinus rhythm. So you have a P wave. That's very good. Okay. QRS complexes are normal. Yes. It is narrow and normal. Yes. What about the PR interval? It is slightly prolonged. Okay. What about the T wave now? T wave, you can see some T inversions here. Okay. You can see some T inversions here. So how about the QRS complexes here? You can see this in lead 2, lead 3, and lead AVF, that is basically the inferior leads, you can see that there is a pathological Q wave. What is this? This is a pathological Q wave or a big Q wave. Like we saw earlier, it is a pathological Q wave or a big Q wave. So like we saw in the history, the patient has had a history of myocardial infarction. Okay, so this makes more sense right now. So this patient is having a big pathological Q wave along with a T inversion. Pathological Q wave along with the T inversion in the leads 2-3 AVF. That means this patient had an old inferior wall myocardial infarction. So this patient has had an old inferior wall myocardial infarction. Okay, so if it was recent, what would happen? We would find that there is an ST depression or there is an ST elevation. There will be some reciprocal changes. All those things will be there when it is a recent or when it is happening right now. Then you will have all those changes. But when it is an old MI, what will happen? You will have pathological Q waves and you will also have a T wave inversion. Okay, so T wave inversions are there in 2-3 AVF and the Q wave is there. Pathological Q wave is there. So that means it is an old inferior wall myocardial infarction. Okay. Then, coming on to the question of whether this patient is having a posterior wall MI or not. So, for posterior wall MI, where will you look at the ECG? So, you basically need to look at the lead V1 and lead V2. This is where we have to look at. So, what happens is, in posterior wall MI, the patient will be having very tall T waves. Okay, very tall QRS complexes in lead V1, very tall QRS complexes in lead V1 and V2. Okay, very tall complexes in lead V1 and V2, and we will also have a T wave inversion. So that is what will happen in a posterior wall MI. Okay, but you might say that this patient is having a QRS complex which is taller than normal in V2 lead, is it not? But what I would say is this patient is having an early transition. This patient is having early transition. What do you mean by early transition? You remember we studied in the previous lectures that transition usually happens in V4, V3, V4. Transition usually happens in V3 and V4. That is the R wave progression. R wave usually it is because the direction of depolarization of the ventricle happens outward. Okay, because it happens in that direction, the R wave will actually be smaller in V1 and V2. However, when it comes to V3 and V4, it will equalize, and V5 and V6, the R waves will be much taller. This is what we had called as R wave progression, is it not? This is called R wave progression. The transition happens in V3 or V4. But if you see in this patient, it happens in V2. It happens in V2. This is because of the leftward axis, because of the extreme axis deviation, that is the deviation of the axis towards the left side. This early transition occurs. So this early transition is because of the axis deviation, but it is not because of the posterior wall MI. You can see here the T wave is completely normal in this. The T wave is completely normal in V1 and V2. The T wave is completely normal in V1 and V2. So what does this mean? This means that there is no ischemic pattern. Is it not? So this patient does not have a posterior wall MI. In posterior wall MI, you would expect tall QRS complexes or tall R waves in lead V1 and V2 along with a T wave inversion. But in this, you will find that in this ECG, you see that the R waves are not that very tall and there is no T inversion. So this patient does not have a posterior wall MI. So to confirm a posterior wall MI, what will you do? You will put posterior leads. Posterior leads. So our chest leads are actually our chest leads will be V1 to V6. But to check for the posterior wall, what we will do is V7 to V9. Okay, these are the posterior leads that you will do. Okay, when you do the posterior leads, then you will actually able to you will be able to confirm your diagnosis. You need to have a very high index of suspicion to actually diagnose this posterior wall MI. Okay, it usually occurs in combination with an inferior wall MI. Okay, so this patient is not having a posterior wall MI and his axis is basically a leftward axis. Left axis deviation, and this patient does not have a posterior wall MI. So we see that this patient had a bold inferior wall MI with pathological Q waves and a T wave inversion leads 2-3 AVF. There is an early transition happening and V2. This is because of the left axis. Okay, so this is what you need to remember, and we have to see this ECG. You can see that this is a normal standardization. Just as a revision, this is a normal standardization, but what we saw earlier was half standard. Okay. Yes. Now we go on to the case scenario 3. Okay. If you have any doubts, you can just post it into the chat box. I will be able to clear it for you. Okay. Now we move on to the case scenario 3. So here's a 42-year-old man. He was brought to the ER with complaints of acute onset of substernal chest pressure. His wife actually says that over the past 2 weeks, he's not been doing that well. He's had fever, myalgia, and sore throat. Okay. So when you see the patient is actually confused and disoriented. His JVP is elevated. His BP is very minimal. His BP is just 70 by 50 millimeters mercury. You insert an arterial line immediately, and the BP shows around 65 to 85 millimeters mercury. Okay, so this is basically a young man who has come to you with complaints of acute substernal chest pressure. Okay, and he's been having complaints of fever, myalgia, and sore throat as well. Okay, so for this patient, you do an ECG immediately. So this is the ECG. So what do you find when you see this patient strikingly? See this ECG strikingly. What is the first thing that comes to your eyes? The first thing that you're able to see will be the ST elevations. Is it not? It is very, very prominent. It is very, very clear that this patient is having an ST elevation. Okay. Where is the ST elevation? It is present in almost all the leads. It is present in almost all the leads except for AVL. Except for AVL, you have ST elevations in all the leads. Okay. So have you come across this kind of an ECG anytime? If you have been to the wards, you will be able to find this kind of an ECG. Okay. So this is what we see is diffuse ST segment elevations. What is this? Diffuse ST elevation. Okay, diffuse ST elevation. In AVR, if you see, you might think that this is an ST depression, but this is basically because the lead itself is inverted. This is ST elevation only. So you can see that ST elevation. But what happens is when you find that there is an ST elevation and you think that the patient is having an ischemic pattern, you will immediately look for a T wave. What will you do? You will immediately look for a T wave. This actually goes hand in hand. ST T wave changes. That's what we call it. Is it not? So ST T wave changes. But if you see in this patient, the T waves are completely normal. Is it not? So the T waves are completely normal. Yes. But this patient is having an ST segment elevation. So what do you think of this patient now? What might this patient be suffering from? So this patient has substernal pressure. He's also had fever and sore throat and myalgia for the past 2 weeks. What do you think? So this patient could probably be having pericarditis. Okay. This patient could be having pericarditis. When I was telling you in our previous lecture about the ST segment changes, I had told you that not all ST segment elevations mean it is an ischemia or a myocardial infarction. ST segment changes can happen in so many other things like pericarditis. Pericarditis is one very, very good example where you will have an ST segment elevation, but it is not really ischemic. Okay, so this patient is having a diffuse ST segment elevation. One more thing that you must remember for pericarditis. What do you think is the characteristic feature that you will see? Okay, what we will be seeing is the PR segment will be very, very short. The PR segment will be very, very short. Okay, PR segment, PR interval will be very, very short. Okay, so what we'll be finding in pericarditis, acute pericarditis will be two things. One will be diffuse ST segment elevation and the second will be PR segment will be short. Okay, these are very, very classic findings which you will find in pericarditis. So this patient, given the history, the patient is having a fever, he's having viral prodrome he's been having, and he's also having substernal chest pressure. What are the other things that you will find in pericarditis? The patient can have chest pain, he can have a pericardial rub, pericardial friction rub, he can develop pericarditis, pericardial inflammation, pericardial effusion. Okay, if the effusion becomes very severe, he can have a cardiac tamponade as well. So all these go on hand in hand in a sequence. Okay, so what you must be doing is you should be able to identify the pericarditis and treat the pericarditis so that there are no complications. Okay, so this patient is having a pericarditis. Okay, because of diffuse ST segment elevation, these are very characteristic features. Diffuse ST segment elevation and not necessarily associated with the T wave inversion. Sometimes there can be a T wave inversion, but not always. And the PR segment will be very, very short. Okay, these are classical findings of pericarditis. So what happens? Do you think that this patient needs to undergo cardiac catheterization? Okay. Do you think that this patient needs to have cardiac catheterization? Because of the ST segment elevations, you might think this patient needs primary PCI. Let us shift him to the cardiac catheterization. No, that's not what we'll be doing, is it not? So this patient needs to be admitted. He needs to be given NSAIDs. That is what we give for acute pericarditis. Needs to be given NSAIDs. We need to monitor him so that he does not develop any complications. So this patient does not need to be shifted to the cardiac catheterization lab. But if he develops cardiac tamponade, if he develops a tamponade, then you must immediately shift to the patient to the cardiac catheterization lab so that you can do a pericardial tap. Okay, so to do a pericardial tap, you need to shift the patient to the catheterization lab and you must do the pericardial tap. Okay, so the most likely diagnosis for this patient with this presentation of viral prodrome with a substernal chest pressure with a very low BP will be acute pericarditis. You need to intervene in this patient immediately. You need to admit the patient and you have to give fluids and you have to manage the patient appropriately. Okay, so the take home message for this ECG will be that for acute pericarditis, you will have a diffuse ST segment elevation as well as a T wave with not normally associated T wave inversions, but a short PR interval as well. Okay, so these are the characteristic findings in acute pericarditis. Okay, so next case scenario. A 32-year-old software engineer with diabetes mellitus comes to your clinic with complaints of intermittent lightheadedness. Okay, but he does not have any chest pain or shortness of breath. He just says, I feel lightheaded occasionally. I have been exercising, but that exercise tolerance has been comparatively stable. I don't find that I'm feeling more fatigued nowadays. There is no such kind of history. Okay, so he does an ECG and he takes it to a healthcare worker and he says that you are having an MI and you need to undergo cardiac catheterization. He's so worried and he comes to you for a second opinion. So what will you tell this patient? Okay, so we'll show you his ECG. So this is his ECG. He's been having intermittent lightheadedness. Now I want you to interpret this ECG. So it's a very easy question. Okay, and it is also a spotter sometimes. So you need to identify this. So you can put your answers in the chat box. So what is this ECG showing? So because of this ST segment elevation, the other doctor or the other healthcare worker or probably his nurse told him that he's having an ST segment elevation. He needs to undergo further investigations. But he's very much worried. His family is also worried. So they come to you. What do you think that this patient could be having? Okay, so let us now look at the ECG normally. You will see that the rate is around I would say 60 to 65 beats per minute. Okay, it is regular. RR intervals are regular. Yes. How about the QRS complex? You can see that there is a P wave. P waves are there. It is a normal sinus rhythm. Okay. How about the QRS complex? It is slightly wide. It is occupying around four small boxes. So it's occupying around 3 to 4 small squares. It's occupying around 3 to 4 small squares. So it is slightly bigger. Wide QRS. Okay, and you have some T inversions here, some ST segment elevation here. Okay, T inversions you can see here. But what is the characteristic finding that you see here? You will be seeing that there is a slight upstroke, what we call as the delta wave. See, this is what we call as the delta wave. Slurred upstroke. What is this? It is a slurred upstroke. I can show you some more leads. You can see here, very characteristic. There is a slight slurring of the upstroke of the ECG. Okay, this is slurred upstroke of QRS complex. Slurred upstroke of QRS complex. What is it? It is the delta wave. Okay, delta wave. This is very interesting. So where do we see this delta wave? Delta wave, we would say it is WPW syndrome. It's a WPW syndrome. Okay, so this patient is a young man, very characteristic, young male with he was usually asymptomatic with occasional symptoms he can develop because of occasional arrhythmias. Okay, and this patient is having a WPW syndrome right now. Okay, he's having a slurred upstroke. So what is delta WPW syndrome? It is a pre-excitation syndrome. Pre-excitation syndrome. Yes. What is the main problem with that? There is an accessory pathway. There is an accessory pathway which will be conducting impulses directly from the atrium to the ventricles. Okay. Accessory pathway is there which causes this pre-excitation. This pre-excitation actually causes this slurred upstroke in the QRS complex or the delta wave as we call it. So this is WPW syndrome. So you need to assess this patient further. Okay. You need to see if this patient is developing any other arrhythmias, and then cardiac ablation is needed if needed. If catheter ablation might be needed, if we have to find out the if we can find out the accessory pathway as well. Okay, so this is an ECG of WPW syndrome. It is very characteristic. 42-year-old male who is usually asymptomatic. Okay, sometimes he might develop some symptom. That's when he will be coming to you. So most commonly, it can also be an incidental finding. Yes, yes. As you rightly told, it is a WPW syndrome. Okay. Next case scenario. I hope it's clear so far. If you have any doubts, you can just put it in the chat box. Okay. So the next case scenario. You are an intern now. You are called in the middle of the night to see a hospitalized patient who has developed an irregular rhythm. He has developed an irregular rhythm acutely, but the patient is fine. He is sleeping in the ward and he's completely asymptomatic. Okay. He is 63 years old and he is admitted for an acute exacerbation of COPD. And you find that in the monitor, he's developed an acute irregular rhythm. Okay. So when you think of irregular rhythm, what's the first thing that comes to your mind? There should be only three things that come to your mind when you say that there is an irregular rhythm, is it not? What are the three things that you will find in a if you find that there is an irregular rhythm? What are the three things that will come to your mind? Yes, first thing will be atrial fibrillation. Atrial fibrillation. The second will be multifocal atrial tachycardia. Multifocal atrial tachycardia. Multifocal atrial tachycardia. The third one will be any atrial tachycardia, especially atrial flutter or atrial tachycardia with variable AV block. Variable AV block. What do you mean by that? AV node is not conducting all the impulses from the ventricle, so the QRS complexes are not regular. Okay, so all the QRS complexes, the P waves are present, but the QRS complexes are not transmitted down to the ventricles. So you will have a variable AV block. Okay, so for this patient, I told you very clearly in the previous class as well. So when you say that the patient is having a history of acute exacerbation of COPD and the patient is developing an irregular rhythm, it will be most likely what we call as multifocal atrial tachycardia. This is a very important thing that you should remember because it's very commonly asked in NEET PG exams, and you can find the diagnosis in just a few seconds. You just need to note these 2 points, and you need to see at the ECG whether it's correlating, whether the P wave morphologies are different. If it's correlating, then the answer is multifocal atrial tachycardia. So it's very simple to know answer, is it not? You can just answer it in a few seconds and concentrate on the questions that you don't know. So multifocal atrial tachycardia in a patient with COPD, the most common arrhythmia that the patient develops will be multifocal atrial tachycardia. So in this ECG, what we'll be looking for will be the P wave morphologies. You can see that obviously there is an irregular rhythm. Irregularity is present. Irregular rhythm. Tachycardic, irregular rhythm. Yes. How about the P wave morphologies? You can see here, this P wave is different. This P wave is different. Yes, this P wave is different. This is different. So this is also different. So you have more than 3 P wave morphologies. More than 3 different P wave morphologies. More than 3 different P wave morphologies. Yes. So it is atrial fibrillation. Irregular rhythm can be atrial fibrillation or atrial flutter or tachycardia with atrial flutter or any other atrial arrhythmia with a variable AV block, or it can be multifocal atrial tachycardia. So in a patient with COPD, most commonly it will be a multifocal atrial tachycardia. You need to go to the ECG and find out if the P wave morphologies are different. If it's more than 3 different P wave morphologies, that means it's multifocal. It means it is multifocal atrial tachycardia. Okay? Yes. This is fairly simple, isn't it? Yes. The next case scenario. Here we have a 73-year-old man with idiopathic dilated cardiomyopathy, and his EF is very, very low. It's around 30%. And he now presents to you with palpitations and dizziness. Okay, he was actually placed in ICD 2 years back. Okay, so why do we place an ICD in a patient with low EF? What is the relation between the two? So in this patient with a structural heart disease and with a low ejection fraction, what happens is they are very much prone to develop arrhythmias. They are very much prone to develop arrhythmias. Okay, so to avoid these arrhythmias, what we do is we place an implantable cardioverter defibrillator. So what happens when the run of arrhythmia is produced, the ICD will start its action and the arrhythmia will be reverted. Okay, and sinus rhythm will be reverted. That's what will happen. That is the purpose of putting an ICD in a patient with this kind of low ejection fraction. So it is a primary prevention. Okay, it is a primary prevention in this patient. You will place an ICD when the patient is having a low ejection fraction. Okay, so this patient is on an ICD, but he is not gone for a checkup. So now he comes to you with complaints of palpitations and giddiness. Okay, so this is his present ECG. What do you find in this ECG? Okay, what do you find on this ECG? So some places you can find that there is a wide QRS. Here you can see that there is a narrow QRS. This is a wide QRS. This is a narrow QRS. Why does this happen? So this patient is actually having a ventricular tachycardia. What is it? It is a ventricular tachycardia. He is having runs of VT. Runs of VT. Okay. So how does this ventricular tachycardia happen? So there is some ectopic focus in the ventricle which is actually triggering impulses. So before a ventricular tachycardia occurs, I told you in my previous lecture that the most common thing that will precipitate a VT will be a VPC. Will be a VPC or a ventricular premature complex. Ventricular premature complex. As you can see here, this is a VPC. This is definitely it is not preceded by a P wave. Yes, and this is a VPC. Okay, it's a wide QRS, and followed by that you have these QRS complexes. Okay, so this VPC is actually precipitating this short run of VT. So what happens? This run of VT is going on, but the SA node is also trying to impart its pressure on the ventricles to contract, is it not? So the impulses from the SA node are also coming. At certain points of time, this SA nodal impulse gets captured. This SA node impulse gets captured and you get a normal sinus wave. Okay, so you get a normal sinus wave. So this capture beat or a fusion beat, capture beat, you can see here as well. Here a normal sinus wave is present. Yes. So these capture beats or fusion beats, capture beats or fusion beats are very, very characteristic of ventricular tachycardia. Very, very characteristic of ventricular tachycardia. So here you can see these are fusion beats. So what happens is this VT is also coming. The impulse for the ventricular tachycardia impulse is also present. The sinus impulse is also coming. That coinciding impulse will be a fusion. Okay, it will neither be a narrow QRS nor a wide QRS. So it will be some kind of this. This is a fusion beat. And that is a capture beat. So capture beat, fusion beats, wide QRS, VPC preceding with the associated risk factors of EF low. Yes, this patient is most likely having a ventricular tachycardia. Okay, this patient is most likely having a ventricular tachycardia. What will you do for ventricular tachycardia? You will shock. Okay, cardioversion will be given for this patient. Okay, so this patient is having, before giving cardioversion, you need to check whether the ICD is working. So you need to reprogram the ICD because this patient is already on an ICD. You need to actually reprogram this ICD to see whether it is working or not. Okay, so for this patient, he's having an episode of ventricular tachycardia. Okay, yes. Okay, now what is this? This is a spotter question. You should be answering it in just a few seconds. So what do you think that this ECG is showing? What do you think is the abnormality in this ECG? Yes, please put your answers in the chat box. What do you think that this ECG is showing? Yes. So this ECG is actually showing what we call as an, what do we call, this is the abnormality, what do we call it as? Yes, I have highlighted the abnormality for you. What do we call it? It is called the Osborn wave. Yes, it is called the Osborn wave. So once you think of Osborn wave, what immediately comes to your mind is hypothermia. Yes, hypothermia. There are a few other conditions in which Osborn waves occur, but the one which is very common and which will be asked in your exams will be Osborn wave is seen in hypothermia. Okay, this is a spotter question. Yes, it's called an Osborn wave. Yes, in hypothermia. Okay, yes. So now most commonly asked, most commons. Yes, most commonly asked, most commons. What is the most common SVT? What is the most common supraventricular tachycardia? Tachyarrhythmia? It is sinus tachycardia. Sinus tachycardia. These one-liners are very important because you can score points very, very easily. You can score marks very, very easily. If you have it on the tip of your fingers, you can just answer it within no time and move on to the next question. Yes. So the most common SVT is sinus tachycardia. Okay. Which is the most common sustained arrhythmia? Which is the most common sustained arrhythmia? The most common sustained arrhythmia is what we see very, very commonly, and many patients have it very chronically as well. It is atrial fibrillation. It is atrial fibrillation. So the most common sustained arrhythmia will be atrial fibrillation. Okay. The next level. Which is the most common re-entrant tachyarrhythmia caused by an accessory pathway? So the patient is having an accessory pathway and the patient is developing an arrhythmia. So we also know patients with WPW syndrome, they can develop, they most commonly develop other arrhythmias like atrial fibrillation. They can have an AVNRT. They can have any kind of arrhythmia. Is it not? So they can even develop a ventricular arrhythmia. So if the patient is having an accessory pathway and he develops a re-entrant tachyarrhythmia, what can it most commonly be? It will be an orthodromic AVRT. Orthodromic AVRT. Orthodromic means the normal conduction happens through the SA node, then AV node, then the ventricles, bundle of hairs and the ventricles, and the accessory pathway will be conducting the retrograde impulse. So this accessory pathway will be conducting the retrograde impulse. So this becomes a vicious circuit. So that is orthodromic AVRT. In antidromic AVRT, what we will be seeing is it will be in the reverse. So the accessory pathway will conduct the normal impulse and this will be happening in the retrograde fashion. So that will be antidromic. Okay. So most common SVT is sinus tachycardia. Most common sustained arrhythmia will be atrial fibrillation, and the most common re-entrant tachyarrhythmia caused by accessory pathway will be orthodromic AVRT. Okay, keep this in mind. You can revise it at any time. It will be very helpful for you during your exams. Okay, so you move on to the next case scenario. A 50-year-old patient developed atrial fibrillation. So you are given a choice of the following group of drugs to be used. So here I have two sets of drugs which can be used in a patient with atrial fibrillation. So I would like you to tell me in which case you will use this group A drugs, in which case you will use the group B drugs. So group A drugs is basically flecainide, propafenone and diazepamide. These are basically class 1 drugs, class 1 antiarrhythmics. Okay, and amiodarone, dofetilide, sotalol and ibutylide. These are basically nothing but class 3 drugs. So I will simplify the question for you. So what I want to know is a patient has developed atrial fibrillation. The patient has developed atrial fibrillation. In which patient will you give class 1 drugs and in which patient will you give class 3 drugs? Okay. So for class 1 drugs, without any structural heart disease, if the patient does not have any structural heart disease, without structural heart disease, then you will give the patient class 1 drugs. Okay. But if the patient is having a structural heart disease, with structural heart disease, then you will give the patient class 3 drugs. This is very, very important. Okay. So if the patient is having a structural heart disease and the patient develops atrial fibrillation, you will prefer giving the patient amiodarone or dofetilide or sotalol. But if the patient does not have any underlying structural heart disease, but the patient is developing a atrial fibrillation. Then you will give the patient class 1 drugs or flecainide, propafenone or diazepamide. Why is that so? That is because, as we all know, all the antiarrhythmics have a pro-arrhythmic action. All the antiarrhythmics have pro-arrhythmic action. The pro-arrhythmic action of these class 3 drugs is much lesser. Okay, but this class 2 drugs is more higher. So if the patient is having a structural heart disease and you give the patient a class 1 drug, the pro-arrhythmic activity will be more. The patient will develop more kind of arrhythmias. Okay, so you need to keep that in mind in a patient who has a structural heart disease. Say if the patient is having left ventricular hypertrophy or the patient is having a heart failure. So which is the drug you will prefer? Amiodarone. Amiodarone, definitely you will be preferring amiodarone because its pro-arrhythmic activity is slightly lesser when compared to the class 1 drugs. Okay, so if the patient is having a structural heart disease, you will give class 3 drugs. If the patient does not have a structural heart disease, you will give class 1 drugs. Okay, so this is about the drugs in atrial fibrillation. So which of the following statements is false? Yes, antegrade conduction causes pre-excitation. Retrograde conduction causes pre-excitation. Concealed pathways conduct retrogradely. Bundle of Kent conducts anterogradely. So I'll give you a few minutes. You can just think over this question. You can put your thoughts together and answer this question. Try answering this question. If you think logically, you will be able to arrive at the answer. Okay. So let me know what it is. What do you think is the answer for this question? Yes. Okay. So, yes, some of you have said the answer is D. Yes, we'll see why it is not true. Okay. So, what happens? This accessory pathway. Yes. So, what do you mean by antegrade conduction and what do you mean by retrograde conduction? Antegrade means atria to ventricles. Retrograde means ventricle to the atria. Okay, so that is antegrade and retrograde. So what happens commonly SA node is there, it is going to the AV node and then to the ventricles. So this is what happens in normal conduction. So when there is an accessory pathway, here. When there is an accessory pathway, pre-excitation occurs. What do you mean by pre-excitation? Pre-excitation means the ventricles are excited earlier. Okay, the ventricles are excited earlier. So what happens when the impulse comes from the SA node to the AV node to the ventricles? There is an AV nodal delay happening. But what happens when the impulse conducts directly through the accessory pathway without going to the ventricle? When it bypasses the AV node, that point of AV nodal delay does not happen. So the so the action potential comes from the SA node directly to the ventricles in a very, very fast rate compared to what will happen normally. Okay, so that is what we call pre-excitation. This ventricle gets excited earlier than what will happen normally when the impulse passes through the AV node. So that is what we are pre-exciting the ventricle. So when this accessory pathway is active and it is conducting antegradely, when it's conducting antegradely, what will happen is there will be a pre-excitation. So just imagine if it is conducting retrogradely. So what will happen? The impulse cannot be generated from the ventricle. So there is no question of a retrograde conduction will not cause a pre-excitation. Pre-excitation basically means the ventricle is excited prematurely. The ventricle is excited earlier. That is what we mean. But when the impulse is coming directly from the ventricle, it does not matter whether the ventricle is pre-excited or not. Is it not? So, retrograde conduction causes pre-excitation is wrong. Okay. So, antegrade conduction only causes pre-excitation. Only when the conduction happens with accessory pathway, bypassing the AV node, when it reaches the ventricle, then there will be something called pre-excitation. But when the conduction happens in the reverse direction, When it is going from the ventricle, there is no concept of pre-excitation actually. Because pre-excitation is basically in reference to the ventricles. It is not in reference to the atria. Okay. So pre-excitation does not occur when there is a retrograde conduction. Okay. So I think this is a very interesting point that you need to remember. So accessory pathways are basically two kinds. Is it not? Accessory pathways, they are basically two kinds. It can be manifest or concealed. Okay. Manifest or concealed. What happens in manifest is the patient will have an accessory pathway. So the impulses will come and this will produce changes on the ECG. This will produce changes on the ECG. This is manifest. So this accessory pathway is manifesting itself. So what happens in a concealed pathway? There is an accessory pathway, but this is not, there is an accessory pathway. Accessory pathway is present, but this is not actively transmitting impulses. Okay, why is it so? Because it is either transmitting retrogradely. Okay, when it is transmitting retrogradely, there is not much change, there is not much happening. Okay, when it is transmitting retrogradely, the obvious changes on the ECG are not produced. Okay, because the normal impulse happens through this way and you will get a QRS complex normally. Okay, so when the impulse goes from the ventricle towards the atrium, this change will not be very obviously seen on the ECG. So that is what we called as concealed accessory pathway. Okay, so this concealed accessory pathway will most commonly conduct retrogradely. So when this changes and it becomes manifest, then it will start transmitting anterogradely as well. Okay, so accessory pathways can be either they can be transmitting anterogradely only, or it can be both anterograde and retrograde, or it can be antegrade. Okay, so this is very, very important. So accessory pathways can be of two kinds, manifest and concealed. If it is manifest, then it will be conducting antegradely. Okay, so now let us now look at the options again. Antegrade conduction causes pre-excitation. That is very, very true. Retrograde conduction does not cause pre-excitation. Okay, retrograde conduction does not cause pre-excitation. And concealed pathways conduct retrogradely. That is also true. Yes, when they become manifest, they will transmit anterogradely as well. Bundle of Kent conducts anterogradely. Bundle of Kent, we have seen it is in WPW syndrome. So we have seen the accessory pathway is transmitting the impulse, that too in the antegrade fashion. Yes. So bundle of Kent conducts antegradely. Yes. So antegrade conduction only causes pre-excitation. Retrograde conduction does not cause pre-excitation. Okay. This is a very, very interesting question. So you can have this for your reference later. Okay. So now we have seen a lot about these things. So it's now time for some one-liners. Okay. So which is the drug contraindicated in in a patient having WPW syndrome when he develops atrial fibrillation? Which is the drug that you should not be giving the patient? Yes. Any guesses? We have discussed this in our previous class. Yes, Sangeeta, you answered the previous question correctly. That's very nice. Yes. So which is the drug contraindicated in WPW syndrome patient developing atrial fibrillation? So it will be amiodarone. Which is one? Amiodarone. Okay. Amiodarone will be contraindicated in a patient with WPW syndrome developing atrial fibrillation, because the AV nodal delay can actually cause the patient to develop more ventricular arrhythmias, because the ventricle will be in a state of excitement. So the patient can develop more ventricular arrhythmias when a patient is developing atrial fibrillation and you give amiodarone to that patient in having WPW syndrome. Okay. So next one. Which is the most common electrolyte imbalance in a patient with TDP or Torsades de Pointes? That will also give you the answer for what is the treatment for patients with Torsades de Pointes. What is it? It is hypomagnesemia. Magnesium. Hypomagnesemia. Okay. Hypomagnesemia. Yes. What is the treatment for Torsades de Pointes? You will give magnesium sulfate. Magnesium sulfate. Where else do you use magnesium sulfate? I think you must be quite familiar by now. Magnesium sulfate you will be using in patients with Torsades de Pointes. You will use in patients with eclampsia, and you will also use in patients who are having very refractory asthmatic attack. In severe asthmatic cases, you will give magnesium sulfate. It is a wonder drug actually. So magnesium sulfate. The most common electrolyte imbalance associated with torsitis D pointers will be hypomagnesemia. Okay. Next, what is the most common electrolyte abnormality associated with pseudo P pulmonale? Pseudo P pulmonale. Yes. What do you mean by pseudo P pulmonale basically? So what is P pulmonale? P pulmonale is when the P waves are taller. Okay. P waves are taller. When does this happen? We have seen two abnormalities of P wave. One is the bifid P wave and the other one will be the P pulmonale. This is the P pulmonale and this will be the P mitral. P pulmonale and the P mitral. Okay. So this happens when there is a left atrial enlargement and this happens when there is a right atrial enlargement. So what do you mean by pseudo P pulmonale? So this patient does not have a right atrial enlargement, but the patient is having a P pulmonale. Okay. So when do you see this kind of an image on the ECG? So that is when the patient is having hypokalemia. When the patient is having hypokalemia. When the patient is having hypokalemia, you will see that the patient is having a pseudo P pulmonale. That is, the P wave will be taller, but the patient does not have any right atrial enlargement. So that patient will have a pseudo P pulmonale seen in hypokalemia. So what are the other things that you will find on a patient with patient's ECG with hypokalemia? You will see U wave. Yes, U waves will be there. The patient can also develop bradycardia. Yes, and some STT changes can also be there. If the patient has hypokalemia, you will be seeing a U wave. There will be an ST segment depression basically, and a U wave will be there. So ST segment depression can be there, a U wave will be there, bradycardia will be there, and a pseudo P pulmonale will be there. Pseudo P pulmonale will be there in a patient who has hypokalemia. Okay. Then Romanov-Watt syndrome is an example of the next question. Romanov-Watt syndrome is an example of, yes, long QT syndrome. It is an example of long QT syndrome. These are very commonly asked in your MCQs. Romanov-Watt syndrome is an example of long QT syndrome. Okay. Next, what is Barlow's syndrome? It's sometimes very nice to know these different names because the question can be framed differently. So that should not put you at a problem where you don't know the other names of the disease. These are a few conditions when you need to know the other names as well. Okay. So what is Barlow syndrome? It is otherwise the floppy valve syndrome. Yes, you must have guessed by now. Floppy valve syndrome. It is the, yes, very good. It is mitral valve prolapse. Yes, Barlow syndrome, floppy valve syndrome, or mitral valve prolapse. Yes, Ashwita, very good. That's correct. It's floppy valve syndrome or mitral valve prolapse. Yes. Okay. So rheumatic mitral valve leaflets. What is the finding that you find when the patient is having a rheumatic fever and he has developed affection of the mitral valve leaflets? What is the characteristic appearance that you will see on the mitral valve leaflets when there is a chronic scarring, when the patient develops rheumatic heart disease? What is the finding on the mitral valve leaflets? What is it? It is very, very commonly asked. And I know this is a pathology question. Yes. But it is good to know. It is the, what is the appearance? Fish mouth appearance. Yes. Fish mouth appearance. Yes. Fish mouth appearance. Or a, what is the other name for that? Is also called the buttonhole appearance. Buttonhole appearance. This is because the orifice becomes very, very narrow because of development of mitral stenosis. Yes. So this is a patient. This patient will have a fish mouth appearance of the mitral leaflets or a buttonhole appearance. Fish mouth appearance or a buttonhole appearance. Okay. So next, one more MCQ. Which is the finding which is true about erythema marginatum in acute rheumatic fever? Yes, it is. Is it pruritic? Does it commonly involve the face? C, is it a very common manifestation? D, usually associated with carditis. So which do you think is true about erythema marginatum? Which is the most common, which is most correct about erythema marginatum? Yes. Erythema marginatum. Yes, I will give you some time for you to put in your answers. Erythema marginatum is one of the major criterion in acute rheumatic fever. It's a major criterion in acute rheumatic fever. Yes, it is not very commonly seen. So the first commonly seen will be polyarthritis. The second one will be carditis. Then the patient can develop chorea. And after that, the most common will be erythema marginatum. Okay, it is not very commonly seen. But when the patient has carditis, the patient will usually have a manifestation of erythema marginatum. So erythema marginatum is very commonly associated with carditis. It is usually associated with carditis. Yes. So this is the correct answer. It is commonly associated with carditis. So how will you describe the lesion of erythema marginatum? Just to revise and recall. So erythema marginatum is basically a irregularly shaped serpiginous erythematous serpiginous macular lesion. Erythematous serpiginous macular lesion with a pale center. You will basically have a pale center. Okay. So erythematous serpiginous macular lesion with a pale center is what we describe erythema marginatum as. It usually occurs on the either the chest or the limbs. That is where we commonly seen. It is not commonly seen on the face. Okay, and it is not pruritic. This is very important to remember. It is not pruritic. Not pruritic. When you study about dermatology, you will be studying about whether the pruritic lesions and the non-pruritic lesions. This comes under the differential diagnosis for a non-pruritic lesion, non-pruritic skin lesion. Yes. Calcifications can also be there. Yes, that's correct. Calcifications will also be there. But I wanted to know about the named appearance, the pathologic finding that you will see, or you would rather say it as the autopsy finding also. So that is what we call it as a fish mouth appearance or a yes. Inflammation can also be there. But when it becomes more chronic, there will be more of scarring. Scarring and calcification will be more commonly seen. Okay, and because of the severe inflammation, the orifice will become very, very narrow, like a fish mouth. Okay, yes, the answer is correct. It is usually associated with carditis. Okay, yes. Some more pathology. Ashraf nodules are commonly associated with, we saw the last class, it was commonly associated with acute rheumatic fever and rheumatic heart disease. Acute rheumatic fever and rheumatic heart disease. This is also called the caterpillar cells. Caterpillar cells will be seen in this. Caterpillar cells because of the aggregation of the nuclei. Ashraf nodules are commonly associated with acute rheumatic fever. Yes. McCallum's patch, that is also associated with acute rheumatic fever. This is basically in the endocardial lesion. McCallum's patch is nothing but an endocardial lesion. Okay. Endocardial lesion. Endocardial lesion happening in acute rheumatic fever who is developing carditis. Okay. And next, this is a very important and interesting question. Which is the necrosis associated with acute rheumatic fever histopathology? So when you say tuberculosis, you immediately think of, a caseous necrosis. Caseous necrosis. Is it not? So in acute rheumatic fever, what kind of necrosis is seen? Yes, it is. What kind of necrosis is seen? It is fibrinoid necrosis. Yes, very good. That's correct. It is fibrinoid necrosis. Yes. So, Ashraf nodules, McCallum's patch, acute rheumatic fever with carditis. Necrosis will be fibrinoid necrosis. Granuloma formation will be there. That will be the Ashraf nodules. Okay. Yes. So, next question. How do the heart sounds and murmurs of mild mitral stenosis differ from that of severe mitral stenosis? So, this question, when you look at it, you feel that it is very complex. But it is very, very simple. I'm just asking you how you are going to identify a patient with severe mitral stenosis. That's how you need to simplify the question so that you are able to answer it. Because I told you the concept is the same, but the way of asking the question will be different. Okay. So, I have given you a set of options here. So, you will now tell me how will you identify and how will you differentiate and which is the correct pair among this to differentiate between mild mitral stenosis and severe mitral stenosis. Which is the correct pair among this? Okay. So, patients with mild mitral stenosis, you will have a loud S1. Yes. You will have something called an opening snap. Yes. Opening snap will be there. You will have a mid-diastolic murmur. And you will have a pre-systolic accentuation. Pre-systolic accentuation. Yes. This is because of the atrium contracting. That will actually give a push and it will increase the sound of the murmur. So that is called a pre-systolic accentuation. You will have a loud S1. So this is seen in mitral stenosis. I want to know how all these will vary when the patient becomes more severe. Okay, what will happen to all these findings when the patient becomes more severe? Yes, that's what we are trying to establish by this question. Okay, so what will happen to the S1? As the severity progresses, the valves become less pliable. The valves become less pliable. So what happens? The S1 will become either soft or it will become absent. Yes, the S1 will become either soft or it will become absent. Yes. Then what happens to the opening snap? We have seen in our class, we talk about the A2OS interval. A2OS interval. The A2OS interval will shorten. Okay. The A2OS interval will shorten. Yes. The S1 will become absent. A2OS interval will shorten. Okay. So A2OS interval will shorten. And what about the mid-diastolic murmur? What will be the duration of the murmur? The duration of the murmur will increase as the severity increases. The duration of the murmur will increase as the severity of the MS increases. Yes. And what about pre-systolic accentuation? Pre-systolic accentuation will be lost. Yes, the pre-systolic accentuation will be lost. So when the patient develops more severe MS, S1 will become absent. Yes. The OS will occur later in diastole. No. The A2OS will interval will actually shorten. Okay. And the duration of murmur will actually increase. And the patient will not have pre-systolic accentuation. So this is what we are trying to find out. When the patient is having a severe MS, you need to know, because this will be commonly asked in your Viva question. When you have a patient who have a long case with cardiovascular system and patient is having a rheumatic heart disease and severe mitral stenosis, then you will be asked these questions for Viva. Okay. So the patient will have a soft or absent S1 and the duration of murmur will increase and the A2OS interval will shorten and the pre-systolic accentuation will be lost. Okay. Yes. Which of the following was most likely to cause acute severe mitral valve regurgitation from papillary muscle rupture? So this question was discussed in our class previously. So this will be, we need to remember that there are two papillary muscles in the left ventricle. There are two papillary muscles in the left ventricle, anteromedial and posterolateral. So this posterolateral one is actually supplied by the right coronary artery. This papillary muscle is supplied by the right coronary artery. So what happens when the patient develops an inferior myocardial infarction, inferior wall MI, this right coronary artery is what is affected. When the right coronary artery is affected, the patient will develop an inferior myocardial infarction. Yes, when this inferior myocardial infarction occurs and the RCA is affected, this papillary muscle will rupture. Okay, so this papillary muscle will rupture and the patient will have severe mitral regurgitation. Okay, so because in inferior wall MI, the patient will have actually a problem with an RCA, which is also supplying the papillary muscle in the left ventricle. The patient will have papillary muscle rupture in inferior wall MI and the patient will have acute severe mitral valve regurgitation. Okay, acute severe mitral valve regurgitation will be present when the patient is having an inferior wall MI. Okay, because the right coronary artery is affected, because it's supplying the papillary muscle. Yes. Okay. So now comes the last question. Which of the following is effective as a bridge to mitral valve repair or replacement in the setting of acute severe mitral valve regurgitation? So you have a patient with acute severe mitral valve regurgitation and you want the patient to undergo a mitral valve repair or replacement. So you're waiting for the logistics to work out. During that time, how will you help the patient to actually improve his dynamics, hemodynamics? Yes, as we all know, in patients with acute mitral regurgitation, what happens is the hemodynamics are severely compromised. The patient will have acute severe pulmonary edema. So the hemodynamic will be severely compromised. Okay. It is not like a chronic mitral valve regurgitation where the heart will have time to actually accommodate. It will have time to get accustomed to the hemodynamics. But in acute, when there is an acute mitral valve regurgitation, what happens? What happens is there will be a acute decompensation. The hemodynamics will be compromised. Okay. So to bridge that gap, what will you do? Okay. you will be doing an intra-aortic balloon counterpulsation. Intra-aortic balloon counterpulsation. This is actually an invasive technique. What you will be doing is, you will put a catheter, you will catheterize the heart, you will actually go till the aorta and you will insert a balloon. Intra-aortic, inside the aorta, you will insert a balloon. So what does this do? Basically, what it does is, this is the aorta. You will now insert a balloon here. Okay. You will now insert a balloon here. This is the heart and this is the aorta. Okay. So you have now inserted a balloon here. What happens during systole is, this will actually become deflated. During systole, this will deflate. During systole, it will actually deflate. So what happens? The blood will actually be able to pass through the, see here, you can see here, during systole, the balloon will deflate. What happens when the deflation occurs? The heart, the ventricle will be able to pump the blood and it will be taken into the aorta very effectively. So the afterload will be reduced. So the effect or the stress on the ventricle will be reduced. So this will improve the myocardial oxygen demand and the supply. Okay, that will be maintained. So when the afterload is reduced, the heart is actually able to pump better. So the myocardial oxygen supply and demand will be maintained. Okay, the heart will not get compromised. During diastole, what happens is, this balloon will inflate. What happens during diastole? This balloon will inflate. When this inflation occurs, this will actually increase the coronary perfusion. So what happens is, this buildup of diastolic pressure inside the aorta will actually help the coronary perfusion to occur. As we all know, coronary perfusion occurs during the diastole, is it not? So when this pressure is increasing in the aorta because of the inflation of the intra-aortic balloon that you have placed, the diastolic pressure inside the aorta will increase. What happens then? The diastolic pressure will increase and the coronaries are perfused better. Okay, so this is a very nice technique. So you are placing a catheter inside the, putting a catheter and placing a balloon inside the aorta, intra-aortic balloon, and during systole it will deflate so that the afterload is reduced and the work or the stress of the ventricle will be reduced. So the myocardial perfusion will be better. Then what happens during diastolic phase? The balloon will inflate and what will happen is, the diastolic pressure inside the aorta will increase basically. So this will happen, this will actually increase the coronary perfusion to increase. So this will help in the patient to maintain the hemodynamics when the patient is actually having when this patient is actually having an acute severe MR. Acute severe MR, you can put an intra-aortic balloon counterpulsation. This technique is done so that you can actually mitigate the patient and you can actually prepare the patient for surgery. Okay, for a corrective therapeutic surgery. Okay, so now we have come to the end of these questions. So I hope these questions were useful for you. Okay, I hope it was a good revision and you have learned a few more important points, a few new points as well, so that it will help you in answering the further questions as well. Okay, I hope the session was good for you and we'll meet in the next classes. So as I have been told, I have been informed by students that the MJ University has announced the exams for you, university exams for the pre-final years. So I think we will continue these sessions after your exams are over, so that all of you will be able to attend and it will be more useful for you. You can attend your exams peacefully and then you can come back to these lectures and then we'll have a good discussion. We'll continue this lecture series after your exams are over. Is that fine? Thank you.
Thank you so much, ma'am. It was a great session. It was the first DNB session in our cardiology series, and we have already completed 6 topics so far. And this session will be useful for the students for attending their entrance exams as well as the MCQs in their own university exams too. Thank you, ma'am. If any doubts, you can just post it in the comment section, or you can just contact us directly through the WhatsApp number given in the description, so that we will get the answer, ma'am, and sorry, we will get the answer from ma'am and tell you. Thank you, ma'am.
Yeah, sure.
And